Good evening, everyone, and thank you for joining our virtual community lecture brought to you by Providence. Our focus for this evening's lecture is heart health. I'm Dana Asano, Executive Director of Cardiovascular and Digestive Health Clinical Institutes for Providence, California. Our guest speakers this evening are cardiovascular experts, Drs. Vishal Patel and Nazanin Azadi. Before we get started, I wanted to let everyone know this is an hour-long presentation. We will have time for questions at the end. Please use the Q&A box to type in any questions that you may have. We will get to as many questions as possible at the end of the presentation. Please note that we are not able to answer any personal medical questions. We will, however, answer general heart-related questions. If we are unable to answer your question, please feel free to email it to calectures@providence.org, and we will get back to you at our earliest opportunity. Again, that was calectures@providence.org. So a little about Providence. Providence, we have 17 hospitals across California to care for all your medical needs, especially when it comes to heart disease. By bringing together expert physicians and experienced nurses, Providence provides complete care to help you maintain a healthy heart, ranging from providing extensive collections of heart disease prevention tips to performing cutting-edge, minimally invasive procedures. Our expert teams can help you maintain optimal cardiovascular health. Lastly, we want you to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or need for treatment. Now it's my pleasure to introduce Dr. Nazanin Azadi. Dr. Azadi grew up in Australia and moved to Maryland to complete her undergraduate studies in biomedical engineering. After medical school, she moved to Los Angeles and was named Resident of the Year at USC during her internship. She was later appointed Chief Fellow after completing a cardiology fellowship at Harbor-UCLA Medical Center and continued to complete her subspecialty fellowship in interventional cardiology. Dr. Azadi is a highly accomplished cardiologist with an extensive background in research and specialized cardiac imaging. With a focus on community education and awareness, she strives to enhance the understanding of cardiovascular disease. Her valuable contributions to the field include published scientific papers, abstracts, and educational exhibits, positioning her as a leading authority at prestigious conferences, such as the Society for Cardiac Angiography and Intervention, also known as SCAI. Additionally, she holds board certifications in echocardiography and nuclear medicine, which further solidifies her expertise in diagnostic techniques. When Dr. Azadi is not working, she enjoys playing piano and spending time with her two sons. And with that, I will hand over to Dr. Azadi for her presentation.
Thanks so much for having me. I'm here to talk to you about your risk and also kind of discuss prevention strategies and really just kind of equip you with things that you need to know to be an advocate for your own health. The focus of my talk is going to be mostly talking about coronary artery risk. And so we'll focus on coronary artery disease, although there are other aspects of heart disease that will be covered in the lecture to follow. So what is heart disease? Heart disease is really three major components to the heart. When you look at the heart, you look at the arteries that give its blood supply to the heart. The heart is like a muscle, and the arteries of our heart kind of give it its oxygen and its blood supply. And they sit on top of the heart muscle, and those are the arteries that when they get clogged or they build plaque inside of them can lead people to have a heart attack. However, there are other aspects of heart disease that are important to consider, and that is structural heart disease, which is when you have valve disease, and the heart has four major heart valves that kind of allow the blood to flow through the muscle, and people can develop thickening or weakness of those valves, and that can also lead to different forms of valvular heart disease. And the third aspect is really the electrical component of our heart muscle. And you'll often hear about people who have heart rhythm disorders like atrial fibrillation, or they have a pacemaker or a defibrillator. And that really talks about or relates to the electrical activity of the heart. So as we go on with the lecture, I'll be focusing really on coronary artery disease and strategies that you can use for prevention or knowing and understanding your own risk. But keep in mind that there's also structural heart and electrical activity of the heart that can lead to disease processes. And these three aspects of the heart can be interrelated as well. we just talked about all the three aspects of cardiovascular disease. The heart is a muscle, and that muscle kind of pumps blood through the heart into the lungs. The lungs oxygenate that blood, and as it comes back to the heart, it's then again pumped out to the rest of our body. So it really is, providing the oxygen and the nutrients that the tissues of our body need, and obviously a very important organ in our health. So when we talk about heart disease in general, it is the leading cause of death in the United States, over 500,000 deaths per year, and this is from the CDC, and it's the leading cause of death ahead of cancer and accidental injuries. And it is the #1 leading cause of death in women, which is why it's so important to have these talks and to really discuss prevention and understand your risk. As I said, my lecture is mostly going to focus on coronary disease and plaque buildup. So we'll be talking about heart attacks, signs and symptoms, and prevention, so you never get to the point where you need to go to the emergency room for chest pain. So what is a heart attack? A heart attack is when the artery that supplies blood to your heart muscle is completely closed off. So you develop a clot inside that artery, and that part of your heart muscle no longer receives the blood supply that it needs, and that causes you to develop chest pain and can sometimes lead to a massive heart attack, which can lead to death. So what are the signs and symptoms of a heart attack? The most common sign of a heart attack is chest pain or chest pressure, left-sided. However, a lot of patients will not necessarily feel chest discomfort, but they'll complain of nausea or abdominal pain. Sometimes they'll feel jaw pain in the left side of their jaw, lightheadedness, shortness of breath. And 2/3 of women who've had a heart attack complain that the few weeks before their heart attack, they've had some unusual fatigue. So those are the signs of a heart attack. Risk factors for a heart attack. Well, there are modifiable risk factors, and there are modifiable risk factors include smoking, which is one of the #1 risk factors for heart disease, and elevated cholesterol. Excuse me. High blood pressure is also a very common modifiable risk factor, blood pressure over 140/90. Low HDL or good cholesterol is often been linked to risk for developing heart disease. Obesity or body mass index greater than 30. Physical inactivity, and diabetes. Family history of premature heart attack in a first-degree relative and a female first-degree relative less than 65 years old. And race, African Americans are known to have a 30% increased risk of cardiovascular disease and death compared to other races. Age over 65. And then when looking at your own personal risk, we talked about obesity, abdominal waist circumference less than 35 inches, physical inactivity. So 150 minutes of moderate exercise is recommended by the American Heart Association. And that's, walking briskly at 3 to 5 miles per hour or 75 minutes a week of vigorous exercise. When we talk about blood pressure, again, high blood pressure is considered any blood pressure over 140/90. When you check your blood pressure, you want to make sure you're checking it 30 minutes after you've been resting, no caffeine in your system, no arguing, don't check your blood pressure right after you've been exercising. So you want to kind of rest and check it. And if consistently it's over 140/90, then that needs to be treated with medication. Low salt diet can also contribute to lowering blood pressure, and a diet that's high in potassium. We have traditional risk factors and non-traditional risk factors. As we talked about, the traditional risk factors of smoking, obesity, physical inactivity, high blood pressure, and high cholesterol, we're also finding that there's a lot of non-traditional risk factors that are showing up as future risk for heart disease. And a lot of these are oftentimes in women: autoimmune diseases, breast cancer treatment, gestational diabetes and high blood pressure during pregnancy. And a lot of these are inflammatory processes. So autoimmune diseases like lupus, rheumatoid arthritis, increased inflammation in the body, can increase your risk of heart disease and should be discussed with your primary care doctor when looking at your future risk of heart disease. Non-traditional risk factors also include radiation and chemotherapy. So if you've had radiation to your left breast or left chest, the American Heart Association and American College of Cardiology does recommend stress testing every 5 to 10 years. Chemotherapy is dose dependent, and your oncologist will oftentimes do a surveillance echocardiogram to look at your heart muscle function if you've been exposed to chemotherapy when looking at your heart risk. We know that patients who have a history of depression don't do well when they do suffer a heart attack. They're more likely to die as a result of their heart attack. And depression is very undertreated in our community. So it does inadvertently add to your risk of heart disease. If you have depression, it's not treated, and then you have a cardiovascular event. In terms of estrogen replacement therapy, there's been a lot of studies, and I get a lot of questions about hormone replacement therapy in women. There is no benefit in taking hormone replacement therapy for prevention of heart disease. It does relieve the symptoms of menopause. It does have some osteoporosis benefits, but the cardioprotective benefits have not been shown. And there was a Women's Health Initiative study that was done that looked at hormone replacement therapy, and kind of the conclusion of that, and what I tell my patients, is that estrogen replacement, if started early on, can have some benefits. But as far as the recommendations and the reality is that if you need to take estrogen replacement for the relief of perimenopausal symptoms, talk to your cardiologist or your primary care doctor about your risk. So if you're someone that's had a heart attack, you've had blood clots, you've had a stroke, then really we would advise against taking any kind of hormone replacement therapy. If you're low risk and haven't had any cardiac events, then it would be a discussion between you and your primary care or your cardiologist about whether or not it would be beneficial for the relief of your perimenopausal symptoms, but definitely not for prevention of coronary disease or heart disease in general. Obviously, estrogen replacement that's administered transdermally has less likelihood to increase your risk of blood clots. But it should not, under any circumstance, be given to reduce your risk of heart disease. We know that coronary artery disease progresses over time. And so whether or not you're premenopausal or perimenopausal or what stage of life you're on, it can start early on and it just progresses over time. So it takes time for that plaque to build up in your arteries. And so the sooner you can start prevention strategies, the better in reducing your 10-year risk or your future risk of having an event. So every day you make choices to try to protect yourself and your family. You wear a helmet, you wear a seatbelt, but you don't really think about how you can protect yourself from the #1 cause of death, which is heart disease. And so we're going to talk about some of the strategies that you can take for prevention. The most important way to prevent heart disease or plaque buildup in your arteries, or to prevent heart failure or congestive heart failure or heart rhythm disorders, is to promote healthy lifestyle throughout life. So all the medications that we give you, yes, they work. Yes, they reduce your risk, but it starts with your healthy lifestyle, and that's how you can prevent your future risk. So if you're between the ages of 40 and 75, you should discuss with your primary care doctor your risk of heart disease over the next 10 years. And there are plenty of risk calculators out there that you can use that take into consideration your age, your smoking status, your weight, your family history, and they can kind of calculate and give you a general idea of what your future risk is of having any kind of cardiac event. So that's where you can start. And if your risk is high, if it's over 10%, you can be referred out to a cardiologist, or you can talk to your cardiologist about what testing you may need to assess that. When we talk about diet, we really, really emphasize a diet that's healthy in the intake of vegetables, fruits, nuts, whole grains, plant protein, and fish. The biggest risk for future events, or what we really advise patients against, is a diet that's very high in animal protein, specifically red meat, because we know that diets that are high in processed red meat have a higher risk of developing plaque and developing disease. So this is kind of the ideal, what you want to eat, and this is what you don't want to be eating. So the American Heart Association, American College of Cardiology has recommendations in terms of the serving size and how much of each of these fruit groups you need to intake. In terms of sodium, they recommend a consumption of less than 2,300 milligrams of sodium per day. We usually tell our patients less than 2,000. If you have high blood pressure, we even try to emphasize less than 1,500 milligrams, which, adds up pretty quickly. If you're someone that does a lot of soups or processed foods, the amount of sodium in those items is so high that you're going to exceed that level pretty quickly in a day. In terms of alcohol, again, the recommendation stays that, 1 to 2 drinks a day is okay. We don't recommend anything more than that, although there's some recent data that shows that after age of 40, 0 alcohol is the most beneficial way to go, but that's for prevention of other disease processes. So in terms of exercise, we talked about moderate versus vigorous exercise. You really need to get moving. What I usually tell my patients is 30 minutes a day, 4 to 5 days a week of some level of moderate exercise. And brisk walking is the #1 way to get that in. So again, moderate intensity exercise is brisk walking at 3 to 5 miles per hour, doubles tennis, dancing, all of those things kind of count as 150 minutes per week or 75 minutes per week of vigorous intensity physical activity. This is kind of an idea of what the recommendations are. Jogging and running at greater than 6 miles per hour, biking, singles tennis, and swimming laps are considered vigorous activity, and we recommend 75 minutes a week of that. So what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? Really, that's what it comes down to. Smoking is one of the worst things that you can do, not just for your heart, but for your lungs. Unfortunately, 1 out of every 8 men in the United States smokes, 1 out of every 10 women, and 1 out of every 7 high school students. But, the amount of inflammation that smoking causes in the lungs and in the arteries of your heart really is what leads to that plaque buildup. When we look at plaque in people's arteries, it consists of inflammatory cells, LDL or cholesterol particles, and platelet cells. And so really to reduce that level of inflammation, you should absolutely not smoke under any circumstance. What about aspirin? So aspirin should be used infrequently. So what the recommendations are now, we don't really recommend taking a baby aspirin in terms of prevention. We think that, women over the age of 64 who take a baby aspirin for prevention actually have a higher bleeding risk. So you really have to talk to your doctor about what is your risk and whether or not aspirin would be helpful in terms of prevention. And usually that's in diabetic patients. However, if you don't have diabetes and you have never had a heart attack, never had a stroke, really there's no benefit in taking a baby aspirin for prevention of future events. Statins are our first line treatment for treating cholesterol. However, there are a lot of newer agents out there that you can talk to your doctor about if you're intolerant of statins. But the goal is really that your LDL or your bad cholesterol should be less than 190. And depending on your risk, so depending on whether you're diabetic, depending on whether you've had a heart attack, that goal changes. So everyone's goal for their bad cholesterol is different depending on their profile. But overall, no one's LDL cholesterol should be greater than 190. Blood pressure, less than 140 over 90 is what's recommended for treatment of blood pressure. If your blood pressure is 120s to 130s, that's okay. If it's over 130 over 80, you really need to make those lifestyle changes to reduce that number. Ways in which you can reduce your blood pressure other than taking medications, like we talked about, the amount of sodium in your diet, so less than 1,500 milligrams, and increasing the amount of potassium. So eating leafy green vegetables is going to increase your potassium level, and that contributes to lower blood pressure. Weight loss is also, a good way to reduce your blood pressure. Physical activity, these are the recommendations set forth by the American Heart Association. And we talked about moderate versus vigorous. And this is just a table kind of showing at what stage you need to be on medication. So as long as your blood pressure is between 120, 129, systolic or the top number, then you don't need medication. You just need to promote your healthy lifestyle. Once you start getting to the 130s, then you really need to look at what is your overall risk. And if your overall risk is high based on all of your other risk factors, if you're a smoker, if you're diabetic, then medication would be indicated. If your overall risk is low, then you can hold off. But then once your blood pressure goes above 140/90, then you really need to talk to your primary care doctor or your cardiologist about starting medication to lower that. The thing about blood pressure is you're not really going to know if your blood pressure is high, because it's one of those silent disease processes that if you're walking around with the blood pressure in the 140s or 150s continuously, you're adding stress to that arteries and that plaque is building up and you're not really recognizing it or feeling it until it's too late, which is why we want to get ahead of that and treat the blood pressure and keep it low so that you're not walking around with that silent development of plaque buildup. So that's all I have. If anyone has any questions, we'll answer them at the Q&A at the end. Thank you very much.
And thank you, Dr. Azadi, for that wonderful presentation. And now it's my pleasure to introduce Dr. Vishal Patel. Dr. Patel is board certified in interventional cardiology, cardiovascular disease, and endovascular medicine. He's a recipient of the Joanne McWhorter Award for Excellence in Clinical Cardiology and the St. Mary's Medical Center Outstanding Teaching Award. Dr. Patel received his medical degree at Baylor College of Medicine in Houston, Texas, and completed his residency in internal medicine at the University of California in San Francisco. Dr. Patel pursued subspecialty fellowship training in interventional cardiology and cardiovascular disease from the University of Texas Southwestern Medical Center in Dallas, Texas. He began practicing in Sonoma County in 2016 and helped to launch the structural heart program at Providence Santa Rosa in 2018. He currently serves as the co-director of the structural heart program. When Dr. Patel is not working, he enjoys spending time on outdoor adventures with his wife, 2 children, and their dog. He loves to garden, cook, travel, and no surprise here, explore the Sonoma County food and wine scene. So with that, Dr. Patel, please take over.
Thank you all for coming. Happy Leap Day. For those leaplings who were born on February 29th, happy birthday, since you only get your birthday wishes every 4 years. It's a special day for you. I've been tasked with talking to you about cutting edge treatments in cardiology. And so for the next 20 minutes, I'm going to talk to you about some of the new therapies that we have in cardiology that kind of avoid open heart surgery, these minimally invasive therapies that Dana was referring to. And we're going to talk about a number of therapies to treat a number of conditions, but the most important one that we're probably going to talk about is transcatheter aortic valve replacement, or as it's known in the business, TAVR. So many of you probably know about TAVR or have heard of TAVR, or have family members who have had a TAVR or a friend who's had a TAVR. But for those of you who haven't, in order to understand what this is, you kind of have to first understand what aortic stenosis is. So on the left, you can see a picture of a healthy aortic valve, which is basically this 3-leaflet sort of Mercedes-Benz looking valve. And normally this valve opens quite widely to allow blood to exit from the main pumping chamber of your heart out to your body. And so your heart can pump lots of good oxygenated blood out to your body and your vital organs. Now, what happens sometimes is this valve becomes diseased or hardened and calcified, such that it really doesn't open very well. It becomes very restricted, or stenotic, we say. So when your heart tries to pump, the valve opens only a little bit, restricting a lot of blood flow from going out to your body. And you can imagine how that would cause you symptoms. There are a few different kinds of aortic stenosis. So worldwide, probably the most common thing is rheumatic or non-calcific aortic stenosis. We don't see a lot of that here in America. What we see more commonly is bicuspid calcific aortic stenosis or tricuspid calcific aortic stenosis. So bicuspid calcific aortic stenosis is where you're born with a 2-leaflet instead of a 3-leaflet valve. And these patients often present in their 50s or 60s with problems related to this valve. What we see most commonly in America, however, is tricuspid calcific aortic stenosis. So where you're born with a normal valve, but over time, for reasons we don't fully understand, this valve becomes hardened and calcified over time. And when that happens, we don't really have medicines that can prevent it from becoming more calcified or medicines that can take away the calcium buildup. Most patients who develop aortic stenosis go through this long latent period where they are doing okay, but their valve is getting progressively worse. And then at some point, the valve gets bad enough that it's severely stenotic, and then invariably patients will develop symptoms. And classically, we say those symptoms are angina or chest pain, syncope or passing out, or congestive heart failure, where you develop swelling in your legs or fluid buildup in your lungs. But I would say what we see commonly in clinic is that patients will present with just fatigue, shortness of breath, inability to do the exercise that they were doing. But regardless of how mild or minimal the symptoms are, once you develop symptoms from severe aortic stenosis, it's really time to do something about it, because as you can see, survival drops dramatically, and 5-year survival is quite dismal without aortic valve intervention. Historically, the only treatment we've had for aortic stenosis had been surgical aortic valve replacement, open heart surgery, where a surgeon essentially cuts out your old aortic valve and sews a new prosthetic valve in. And that's a great procedure still today. And many patients actually still undergo surgical valve replacement. But what we do actually more commonly now than surgical aortic valve replacement is transcatheter aortic valve replacement. So these are 3 transcatheter aortic valves that are commercially approved in America. So we have the Sapien valve, the Evolut valve, and the Navitor valve. And basically all of these are metal frames, as you can see, with a tissue valve that's either mounted or sewn inside that are designed to be crimped down and inserted into the body to replace your current valve. Here's an animation of how the procedure works. So a catheter is typically inserted most often through the femoral artery over a wire, and then that catheter usually is can either release or you can deploy the valve if it's mounted on a balloon across your current valve, and then with the next heartbeat, basically this new valve starts functioning right away. That catheter and wire are then withdrawn, and then the hole, the small incision that's made in the artery is typically repaired in a percutaneous fashion, meaning a non-surgical fashion, with a couple of special devices that we use. And this procedure works really well. So here's an example of a patient that was treated at a Providence facility, a 96-year-old woman who had been having symptoms of progressive shortness of breath, and actually had no other real medical problems. And so it was her aortic stenosis that was causing her to feel progressively worse. And she was actually having trouble staying independent at home. And she had a dog and was actually telling us how she had trouble walking her dog. And so she was seen in a Providence institution and thought to be a good candidate for TAVR. And this is the video of her procedure. So you can see there's a little catheter here, and we're injecting dye into the aortic root to position this valve. And this valve is mounted on a balloon, which is then inflated, which expands the transcatheter valve stent, which is then left behind, and all the other equipment is removed. This procedure takes less than an hour in most cases nowadays. It uses pretty minimal contrast dye. Patients are typically walking around the same day. Most patients stay 1 night in the hospital, though I'll say that as the procedure has become safer, some select patients are actually able to go home the same day of their procedure now. Most patients just take a baby aspirin after the procedure, and this patient was feeling back to normal, able to walk her dog and stay independent in her home. So while we can do this for patients with what we call native aortic stenosis, so you're born with a valve that becomes stenotic, we can also do this for patients who have failure of a prosthetic valve. So some patients end up getting surgical valves, and those last anywhere from 10 to 15 years, some longer, some less. And if those valves fail, oftentimes we can do what's called TAVR in TAVR in a failed surgical aortic valve replacement. So this is a patient who had a prior surgical aortic valve. You can see here by this frame, that's the old surgical aortic valve. And we were able to put an Evolute transcatheter valve in there, obviating the need for redo open heart surgery, which can often be a big ask for some patients, especially as they get older. TAVR has been around for long enough that now on rare occasion, we see some failed TAVR valves. And so we can actually on occasion do TAVR and TAVR, not always, but sometimes. So here's an example of a patient treated at Providence who had a prior Edwards Sapien valve that failed and was able to have an Evolute valve placed inside that. And the opposite has also been done. This is a patient who had a Medtronic Evolute valve that failed, and they had a Sapien valve placed inside that. So as you can see, there's a lot of options now for treating patients with aortic valve disease, and this space is only growing, and I expect we'll have even more options in the future. Next, I want to talk to you about transcatheter mitral valve therapies. So the mitral valve, like the aortic valve, sits on the left side of the heart. But unlike the aortic valve, the mitral valve is very complex. So it consists of two leaflets that are multi-scalloped that sit in this sort of space called the annulus. And the leaflets are tethered by these structures called chordae that then attach to the muscle of the heart called the papillary muscles. And all of this together we call the mitral apparatus. And so all the parts of the mitral apparatus have to work in harmony for the mitral valve to function correctly. And so you can have any, a problem that we commonly see with the mitral valve is mitral regurgitation or leaking of the mitral valve. And it can be caused by a dysfunction of any of those parts that I just showed you. So you can have prolapse of a leaflet. Those cords can actually rupture, causing the leaflets to flail, or you can get enlargement of the annulus or the ventricle itself, which causes the valve to leak. And when this valve leaks, you may have symptoms of shortness of breath or exercise intolerance. And the worse it leaks, the worse your survival is. So in patients who have severe mitral regurgitation, shown in this dark black line here, survival at 5 years without treatment is about 60%. So significant risk of dying if you have untreated mitral regurgitation. And the standard of care today is still mitral valve surgery, so open heart surgery to repair or replace this valve. But some patients, and actually many patients, are not candidates for mitral valve surgery due to either age or comorbidities that make them high risk for traditional mitral valve surgery. And there are a number of therapies that are being developed, but some that have been approved. And one in particular, the MitraClip procedure, is one that we offer patients commonly. So this is where a clip is inserted through a catheter from the vein, from the right atrium over to the left atrium and positioned above the mitral valve. And the idea of this clip is to try to clip the leaflets together at the spot where the valve is leaking. So this clip can be advanced down across the mitral valve, and then it can actually be withdrawn to grasp the leaflets as they're moving. And one of the great parts about this procedure is that if you don't like the first position, you can actually open the clip and move it to a more favorable location. And once you get it in just the right position, you can then deploy the clip. And what it creates is this double orifice or two-hole sort of mitral valve where it should not leak at the clip, but and it should still open on the sides of the clip. This procedure isn't perfect, but it's very good. So it usually results in at least a 2 or 3 grade reduction in the amount of leaking of the mitral valve. And usually that's enough to make people, to make patients feel better and they do quite well with it. And sometimes it's really the only option for patients. So this is a patient who was treated at Providence who had presented with severe mitral regurgitation. So that's all this color that you see, sort of a mosaic color pattern here, that's leaking across the mitral valve from the left ventricle into the left atrium back towards the lungs. And this patient had a leaky mitral valve because of a large heart attack causing a rupture of that muscle of his heart. And patients like this historically do really poorly with surgery, with a risk of dying of upwards of 50%. So after a thorough discussion by an interventional cardiologist and a cardiac surgeon who are experienced in mitral valve intervention, it was actually elected that this patient undergo a MitraClip procedure. And this is the patient's MitraClip procedure. So you can see a clip being positioned here under the mitral valve, exactly where that sort of flail part of the mitral valve is. And when it's positioned correctly, the clip is then closed. eliminating that problem with the mitral valve. And this patient went on to get an additional clip and had very minimal residual leaking of their mitral valve, such that they were actually able to leave the hospital about a week later from a condition that typically would be almost certainly mortal. In addition to clipping the valve, sometimes we can actually put a new valve inside an old failed mitral valve. So just like we can do that for the aortic valve, we can now do that for the mitral valve. So if you've had a prior surgical mitral valve replacement and that valve fails over some number of years, sometimes we can actually put one of those Edwards sapien valves inside that old valve, obviating the need for redo open heart surgery. And some patients who've had a prior mitral valve repair will have a mitral valve ring. And most repairs do quite well, but on the off chance that repair fails, we can actually often put a new transcatheter valve inside that ring. Many companies are working on lots of new mitral therapies on the horizon, targeting those different areas of the mitral valve that I showed you. So some people are working on, can we treat the annulus and bring the annulus in? Can we actually do a full valve replacement like we do for the aortic valve, but it's much more complicated in the mitral position? Hopefully we'll have more data as some of these clinical trials are completed over the next few years. So we've talked about the two left-sided heart valves. Now we're going to move on to the right-sided heart valve, the tricuspid valve. So tricuspid regurgitation or leaking of the tricuspid valve is a problem we commonly see, and it affects about 5 to 8% of the population. And when the tricuspid valve leaks, you can have symptoms of shortness of breath, swelling in the legs, swelling in the belly, fatigue, or just declining exercise capacity. And surgery, isolated surgery for tricuspid valve disease or tricuspid regurgitation is really not great and not associated with great outcomes. So we typically only do surgery on the tricuspid valve when patients are undergoing heart surgery for other reasons, or if the tricuspid valve is infected. Otherwise, we typically manage this medically. But unfortunately, medical management of a leaky tricuspid valve isn't great. So these are patients who have congestive heart failure, who have really leaky tricuspid valve shown in red. And as you can see, survival is quite poor in those patients. So we really need some therapy to try to reduce the tricuspid regurgitation in these patients. And, there are a number of devices that are being developed to try to target all kinds of different parts of the tricuspid valve, the annulus, putting a clip on the tricuspid valve, just like we do for the mitral valve, trying to put stents in the tricuspid valve. And we really had no FDA-approved devices until about a month ago. And that's when the Evoke transcatheter tricuspid valve replacement system was approved. So this is a full transcatheter, meaning, put in through a catheter in the leg, replacement of your tricuspid valve. So this device has these unique little anchoring devices that can be opened to capture your tricuspid valve leaflets. And when the leaflets are adequately captured, the valve can then be fully deployed and released. And it looks quite simple here, but it's a very complex procedure and has only just been FDA approved, but does result in improvement in quality of life, relief of symptoms, and improved ability to exercise. And so we'll probably be seeing a lot more of this now that this device has just become available. So far we've talked all about valvular therapies. The last thing I want to talk to you about today is left atrial appendage occlusion. So many of you probably know what atrial fibrillation is. It's a very common heart rhythm problem. So normally your heart should beat pretty regularly. When your heart's in atrial fibrillation, it beats really irregularly. And that's because the top chambers of your heart, or the atria, are fibrillating or quivering. And when the top part of the heart is quivering, blood really doesn't circulate through the top part of the heart well. And when blood doesn't circulate well, when it stagnates, it can clot. And if those clots break off and go places, they can cause problems like strokes. And so many patients with atrial fibrillation are treated with anticoagulants or blood thinners to prevent or reduce their risk of stroke. And this is a great therapy for the vast majority of patients with atrial fibrillation. But there are some patients who are just at increased risk of bleeding who are not good candidates for anticoagulants. And those would be patients that are older, patients who've had prior bleeding issues on anticoagulants, patients who've had a prior stroke, those with liver or kidney problems, high blood pressure, or genetic causes for having increased risk of bleeding. And for these patients, we used to really have no options to treat them other than to stop their blood thinner and then accept that they were at an increased risk of stroke. But it turns out that most of these clots that occur in atrial fibrillation originate in what's called the left atrial appendage. And that's this little outpouching off of the left atrium. And so we don't totally understand what the structure does, but basically clots can form there when you're in atrial fibrillation. Over 90% essentially come from that area. So it sort of stands to reason that if you can close off this appendage, maybe you can reduce people's risk of stroke. And that's exactly what we've learned, is that if we put a device in there to close off that left atrial appendage, we reduce patients' risk of stroke comparable to what they get with blood thinners. So there's a couple of devices that are available now. This is called the Watchman device, which is like sort of a metal cage that's covered with this fabric to try to close off that left atrial appendage so that any clots that form in there get caught and stay in there and can't break off and go and cause problems in your body. This procedure, a Watchman, or there's another device available, is typically done through a catheter that's placed in the leg, often under general anesthesia, though sometimes it can be done without general anesthesia. It takes about an hour, and patients can be discharged the same day typically, and it eliminates the need for blood thinners. Here's an example of a patient that was treated at Providence with a Watchman device. So this is the operator's performing what's called a tug test, trying to make sure that that device is really snug in there. And once they're satisfied with it, they can then release the device and take all the catheter out. So in conclusion, we've had a lot of significant advancements in cardiology and interventional cardiology over the last decade that really, with a lot of numerous new devices and procedures that have allowed us to treat a wide array of conditions and disease states. And we expect continued innovation in this space. And I suspect that if we were to do this talk again in another 4 years on the next Leap Day, we'd probably have to have 40 minutes because there would be so many new devices out there to treat so many new conditions. And with that, I'd be happy to take any questions.
All right. Thank you, Dr. Patel, for that informative presentation. I think we'll definitely, 4 years from today, we'll come back and do those advances. I think you're right. It's changing so fast. It'll be a fascinating topic yet again. Before we begin our Q&A, we have a few questions for you, our participants. We would appreciate your honest feedback answering the poll that you see on your screen. It is our goal at Providence to provide useful information to our communities that rely on us for their care. So please take a few moments and answer those questions to help us get some real-time feedback on our webinar. And now we will jump to the Q&A. I know many of you have been putting questions into the Q&A. We've been answering some of those along the way. Please continue to ask those questions in the Q&A. I'm going to ask Drs. Azadi and Patel to come back on screen. We will do some answering of the questions in real time. I know there were some very interesting questions that were in here. Perhaps we can expand on some of those. There were some questions about what were the right types of tests. Let me go back to this one. Just scroll through here. Many questions about the download. We're going to revisit that. And then there was a question. What are the recommended testing options to evaluate heart health? So Drs. Azadi and Patel, would you like to expand on some of the diagnostic tests that patients may need to receive prior to jumping into interventional solutions?
Sure, I can comment on that briefly. Again, what I would suggest you start with is either your primary care or your cardiologist can give you a risk score based on all of the risk factors that we discussed earlier. And based on that risk score, then they determine if you need any testing. When it comes to coronary disease or blocked arteries, one of the most common and easiest tests is a very straightforward exercise treadmill test where they put you on a treadmill, get your heart rate up to a target level, which is usually 85% of your maximum. And they look at your EKG to determine if there's any changes on your EKG when you're exerting yourself that would suggest that you need that you may have a blockage, and that's a very, very basic test. And then from there, there is some more in-depth testing that they can do, but it really would depend on your personal risk and whether or not that test is warranted. It's not a screening test per se, it's more if you have symptoms or if you have risk factors that put you at higher risk, then they may warrant a stress test of some kind to assess that. In terms of valve disease and some of the things that Dr. Patel discussed, oftentimes your primary care or your cardiologist will hear a heart murmur that might suggest that there's some dysfunction with one of your heart valves, and that would lead them to recommend an echocardiogram, which is an ultrasound of your heart, to really look at all those valves and look to see if any of them are leaky or thickened or not functioning well.
Thank you for that. There was another question that came in. What are your thoughts on the benefits of calcium scoring?
I'd be happy to comment. I think calcium scoring is a great test and adds sort of additional leaves in the tea leaves that we try to use to predict your risks. So, everybody's at risk for heart disease. We have traditional risk factors that we can look at. But what we've realized is that traditional risk factors don't capture all of the patients who are at risk. And sometimes additional tests like a coronary calcium score can help us identify those patients who wouldn't have necessarily been picked up by traditional risk factors who might benefit from cholesterol lowering therapies. And it can also do the reverse. It can take patients who are in this gray zone of intermediate risk and say, should you take a statin or not? And if you have a really low coronary calcium score, it might suggest to your doctor that maybe you wouldn't benefit as much from statin therapy and you can just continue with diet and exercise and lifestyle. So I think they're a great test and just add more data for us to help individualize patients' risk scores.
And Dr. Patel, looks like a question here directed to you regarding ablation. Is heart ablation safe and effective treatment for AFib? And we talked about LAAO.
Yeah, so ablation in the modern era is actually generally a safe and very effective procedure for controlling atrial fibrillation. There are other ways to control atrial fibrillation as well with medications, but many patients are not candidates or cannot tolerate medications, or sometimes medications are not effective. And in those cases, ablation can be a very effective strategy for managing atrial fibrillation.
What are your thoughts on wearables? Rings, watches? Patients are asking either of you, ways to really monitor, and Dr. Azadi, your comments about staying active and what to eat, things of that nature. What are your thoughts on wearables? And
yeah, I think wearable devices are great. I have, some reasons I think they're good. If you're exercising and you really want to get that cardiovascular benefit, I tell patients you really want to achieve the 85% of your maximum heart rate. Your maximum heart rate is 220 minus your age, and if you get to 85% of that, you're really hitting that cardiovascular zone. So having a wearable, you can actually, assess your heart rate and assess if you're getting adequate exercise. The wearable devices, some of them have EKG monitoring. These devices are not meant to detect a heart attack, and they will not, but they are helpful sometimes in detecting arrhythmias or irregular heart rhythms. And I often have patients send me, snapshots of their EKGs on their iPhone, or they have what's called the Cardia device, which attaches to the back of your iPhone and records your heart rhythm. If they're having palpitations or irregular heart rhythms, it's a good way to record that and review it with your cardiologist or your primary care doctor to see if there's an irregularity there. So yeah.
one of the questions in the chat earlier was surrounding what type of doctor to see. So you mentioned primary care. We obviously both of you are interventional cardiologists. When is the right time for a patient to make that transition from a primary care doctor to seeing a cardiologist?
So I think, in the hands of a good primary care doctor who can really assess your risk, If they look at your risk factors and you have, a high risk of heart disease based on all of those risk factors, I think it would be a good time to refer you over to a cardiologist who then can really focus on what you can do to reduce your risk, so they can address each of your risk factors, whether it's high blood pressure, cholesterol, diabetes, and really help you reduce your risk. Or if the primary care doctor feels like you're so high risk that you may need further testing, then it would be a good time to refer over for those tests, which can be done through your cardiologist's office. Interventional cardiology, hopefully you would never have to see one, but that's the point where you need treatment, or you may need a stent or an angiogram or a procedure that would be diagnostic as well as therapeutic. That would be the time you would see an interventional cardiologist.
Thank you for that. We have several questions coming in about statins. So one is, how do statins stabilize soft plaque?
So, statins have several properties. One of them is that they lower the LDL particles that are part of what makes up plaque. They also have an anti-inflammatory property, which reduces the inflammation and creates kind of like a stable cap over the existing plaque, so that that plaque is not unstable and doesn't rupture and cause a heart attack, and mainly, prevent progression of that plaque disease. So I often am asked, is there anything I can do to get rid of the plaque that I have? Well, no, you can't really get rid of the plaque that you have. There's some studies that show statins and plant-based diets may have some role in plaque reversal, but that's never really panned out. But really, the role of statins is anti-inflammatory, reduction, a stabilization of LDL particles, so that that plaque doesn't get worse and doesn't continue to build up in the artery and close off the artery.
And what would an alternative be if a patient cannot take a statin?
So there are lots of alternatives that are coming out. One that's been really used more often lately are the PCSK9 inhibitors, Repatha and Praluent. They are injectable medications, either once a month or once every 2 weeks, that are very effective in lowering your cholesterol. And that's one of them. There's a lot of other newer drugs, Nexletol, Inclisiran, that have come out that can be helpful in lowering your cholesterol. So if you're intolerant of statins, I would suggest talking to your cardiologist or your primary care doctor about an alternative. There are ways we can get your LDL down. It doesn't always have to be a statin, although statins are first-line treatment right now.
We're at 6:28, so this will probably be our last question. Someone asked, is there a useful life, excuse me, to stents?
So, it sort of depends on the patient and the anatomy and the stent. We're now on, probably 5th or 6th generation drug-eluting coronary stents. And generally speaking, when deployed correctly with a good expansion, the likelihood that the stents re-narrow over time is pretty low. I'd say probably less than 5%. And in some cases less than 1%. So generally, they're pretty good, and it just depends really on your specific individual condition.
Great. Thank you for that. And thank you all for attending this lecture. If you have questions that we did not get to, remember you can send those to calectures@providence.org, and we will get back to you as soon as possible. So again, thank you for attending the lecture and for all the excellent questions, and a big thank you to Drs. Azadi and Patel for taking the time to provide us with this very valuable information. We will be sending a recording of the presentation to all of you that attended. You can also find it posted on our Facebook pages and also on our YouTube channel, and you can access that by typing Providence in the search bar. As mentioned earlier, you can see on the screen, we have 17 hospitals across California. You'll see it there on the map. And to find a physician or to schedule an appointment, we have numbers for Southern California and Northern California. So if you reside in Southern California, please call our Patient Engagement Center at 844-564-7768. And if you reside in Northern California, please call 833-923-3556. And you can also visit us 24/7 on the web at providence.org. You can click on the Find a Doctor tab in the navigation bar, and that will take you to our many physicians that are available to care for you. We do look forward to caring for you and for your loved ones. Thank you again, and have a wonderful rest of your evening.